Okay, good afternoon. My name is Adegboyega, consultant pediatrician. Today we are going to be talking about sickle cell anemia. By way of introduction, sickle cell anemia is an inherited disease from parents and have to do with exchange of amino acid from one position to the other. There are quite a number of diseases that look like sickle cell. In a nutshell, most of these diseases have to do with hemoglobin, abnormal hemoglobin, and actually called hemoglobinopathy because it's an abnormal hemoglobin. It includes sickle cell anemia, and sometimes we don't even call it sickle cell anemia because that's not the only thing. We rather call it sickle cell disease, and it also includes diseases like thalassemias. We have different type of thalassemias. But today we are looking at sickle cell disease. And when we say sickle cell disease, it means we're talking about a form of inheritance, which may be sickle cell anemia, in which you have a combination of the X chromosome, two of the X chromosomes. It could also be in which you have sickle cell with other disease condition. You can have AS, you can have SC, and sickle cell with thalassemias, especially S-beta thalassemias. And it's a disease that is common among blacks and people from the Mediterranean area. Sickle cell is not a bacterial infection, neither is it a viral infection, but it's an inherited disease condition. And it is common in parents that have the sickle cell trait or sickle cell disease itself. So if a parent has sickle cell anemia, sickle cell trait, like they are SC or S thalassemia, and the other parent also is a carrier of sickle cell gene, the likelihood of having sickle cell anemia is common. Now, how do they present? They present usually commonly at around the 6 months of age. Usually they don't commonly present when they were born. But now we can do tests to detect the S gene as early as when they are born, from the first day of life. And how do they present at 6 months of age? They usually present with dactylitis. There's a swelling and pain in the hands, the fingers, sorry. That is how they present commonly. But later in life, they have other features, which will include bursting of the frontal bone, the skull. It could include jaundice, anemia. It could also present with, they have this habitus, what we call the sickle cell habitus. They are usually asthenic, so to say, but not all of them. Some of them are actually big enough that you may not be able to know if they're sickle cell patient or not. And there are different haplotypes. We have the Banju, the Benin haplotype, and different haplotypes. And that also gives us an idea of the severity of sickle cell anemia. They also have crisis, and the crisis includes 4 major crises in sickle cell patients, and that is hemolytic crisis, aplastic crisis, or aplastic anemia. They also present with sequestration crisis and hyperhemolytic crisis. So these are common crises that they do have. But apart from that, they also have some other complications because of the sickled cell, which means because of the sickle red blood cell, the blood is not able to flow easily through the vessels. and that may result in blockage. And some of them can actually present with cerebrovascular accident, like a stroke, and they may be unconscious, and the stroke need to be managed. Those are other complications. They could also have renal disease. They present with nephrotic syndrome. They could also present with acute renal failure. They present with complications like priapism, in which they have their phallus being enlarged and hard without a sexual arousal. So there's so many other complications that they do have. By way of investigations, when they present this complication or this crisis, might actually be due to the fact that they have an infection, malaria or sepsis, the fact that they are dehydrated, the fact that they are stressed in school. So that could precipitate a crisis. And by the time we do a full blood count, the full blood count will give us an idea of the possibility of an infection. Usually the WBC of the white blood cell of a patient with sickle cell anemia may be on the high side, because they usually have their new or reticulocyte count being counted as part of the WBC. And so what we do is to do a corrected WBC so that we can know the actual value. HB genotype is what we do by way of hemoglobin electrophoresis to determine if a patient is having sickle cell anemia or not. There are other investigations that can also be done based on the dilution test and several one of them. But what we need to know is that sickle cell anemia does not affect the intelligence of a child. If it's well managed, a lot of these children, they do well naturally, if the stress is also being prevented and they are able to take their drug normally. By way of treatment, what is being done is that when they're having crisis, we manage them for their crisis. If it's anemic crisis or aplastic anemia, we have to transfuse. Aplastic anemia in sickle cell patients have a better prognosis than other aplastic anemia because it's caused by a virus known as parvovirus, and that can be taken care of, and that ends it. If they have sequestration crisis, it means that a lot of the blood has pulled into the reticuloendothelial system, like the liver, the spleen, and one has to be careful transfusing patients who are having sequestration crisis. We may have to give them like half of what we'll have given them if they're having severe anemia. So we may have to give 5 ml per kg of packed cells. In severe VOC is classified based on the severity. Sometimes we use the non-steroidal anti-inflammatory drugs, which are usually adequate. But if they are not getting good response, we can move on to things like the DF418, and we give them stronger analgesia. Fluid rehydrating a sickle cell patient is also important. What we do is to give them about 150% of maintenance fluid. Then we also place them on paludrin to go on with as a prophylaxis for malaria prophylaxis. They are also placed on folic acid, daily folic acid. Iron in sickle cell, it depends on our findings on serum iron level, or our finding on full blood count. If they are having microcytic hypochromic anemia, we may need to give them iron if they are deficient. But because they are also hemolyzing, they may also be recycling this iron, and they may also have iron stored in their system. So they may not necessarily need iron at times. So it's not necessary that all sickle cell patients be placed on iron supplements. And apart from that, if we do from time to time do some investigations, like every 6 months, we ask them to do a TCD, like a transcutaneous Doppler. And if chances of having a stroke is high, based on the Doppler result, we may need to commence some of these sickle cell patients on hydroxyurea. And sometimes there may be need for recurrent transfusion in sickle cell patients so that the chances of having a stroke is reduced in them. One thing that we should know is that they need a lot of support, social support. There are actually different kind of clubs, and sickle cell club is also available for patients and for parents of these sickle cell patients. In our hospital, we also organize a yearly event for them where they meet, and that have been very helpful. And government may need to come also to the aid of these parents, because some of them are actually not rich enough or buoyant enough to even be able to do a TCD, a transcutaneous ultrasound, the Doppler, that will help to monitor the cerebral blood flow, which will tell us if they are more predisposed to stroke or not. There are quite a number of complications that will arise from sickle cell anemia. I've mentioned some of them earlier on. But the prognosis for survival in terms of mobility is good. But in terms of morbidity, it means that they might also have some other complications that they may have to live with. So invariably, what we ought to do, it is better not to have a patient with sickle cell anemia at all. But if we have them, in our countries, we don't have the wherewithal to be able to do gene therapy or a bone marrow transplantation. Because if we are able to do that, it means that they will do well, because the bone marrow will be renewed and they will start producing normal hemoglobin that is necessary for survival. But even at that, it is not good for the sickle cell patient to marry another person that carried the trait, the sickle cell trait. Because despite the bone marrow transplantation, the trait is still there. That does not remove the gene, it does not change the gene. So they are still likely, most likely to have a sickle cell patient as a child, So by and large, we have been able to talk about sickle cell anemia. I've only been able to whet our appetite, to have an idea, a clue of what sickle cell anemia is all about. I believe that there may be questions that if you have questions, you can post it so that we'll be able to answer. Questions actually sometimes help to unravel or to solve some of these challenges better. When you ask questions, we might be able to tackle that question and you understand it better. But let it be something that will whet our appetite to ask questions and to manage to some extent the patient that have sickle cell anemia. But it's always better for them to be managed in the hospital. We don't necessarily have to see them every week. If they are doing well, we may give appointment of up to 6 months, for them to go home and, have good time and come back in 6 months. That's what we do. So thank you for listening and have a good day.